Can you see my slides?
Yes,
Are
but
they in
not in
slideshow?
slideshow.
Okay. How about now? Are they in slideshow?
Not yet. Yes, doctor, now they are in slideshow.
Okay, so here you see the buccal pigmentation, the buccal mucosa pigmentation here. It's even more obvious here on this in this picture. And mind you, it's inside the buccal mucosa opposite the molar teeth, right? So in edentulous patients, in patients who don't have any molar teeth and who don't wear a dental prosthesis, you don't expect to find this buccal mucosal hyperpigmentation, okay? So this is a hyperpigmented buccal mucosa. And also you can find the hyperpigmentation opposite on the lower lip, opposite to where the upper incisors compress, you see? Okay? Hyperpigmentation on the inner aspect of the lower lip. Okay? Is it clear?
Yes, doctor.
And this is vitiligo, you see? This is the normal skin color. But this is a large patch of milky white depigmentation, which is autoimmune in nature, and it can occur with Addison's disease as well, vitiligo. Okay? And this is a hyperpigmented scar. You know that scars of surgery, they may have different colors depending on the age of the scar. At the immediately after surgery, it is pink to red in color, and then the color fades away bit by bit until it becomes almost skin color. But then here you notice that this is the normal skin, but here you see the scar becomes dark brown in color. And this irritates ladies. They come running, okay? So hyperpigmented surgical scar. This is a very nice slide, which I like very much. These are two twins, okay? Twin sisters. One of them has Addison's disease. Which one do you expect? Which one?
The one on the right side.
Yes, why? Why do you say the one on the right side? Why?
She looks, the skin color is more pigmented.
Yes.
She looks pale.
She looks pale and hyperpigmented. She has darkened lips, you see, and she has lots of weight. You see, the sister appears, they are Caucasians, by the way, huh? جنس الأبيض يعني. So the skin is fair and she has a nice pink complexion, which is normal, and she has normal weight. But her twin sister, the one with Addison's disease, has lots of weight and she has, you see, dark skin with hyperpigmentation in the lips, you see? So, of course, it's the one on the right, right? Okay. Now coming to add, so far, any problems? Huh?
No, doctor, it's
Okay.
No.
Coming to the imaging. This is a plain X-ray of the abdomen, AP view or PA view, showing what? This is these are the vertebrae. This is the last rib, right? And here is the renal angle type. You see here white specks of calcifications. This is the area of the adrenal glands. Why are the adrenal glands calcified? Because this patient has fibrosis of the adrenal glands due to post-TB, and on top of these fibrosed adrenal glands, 50%, in 50% of cases, calcium can deposit, and calcium appears white on plain X-ray. All right, is it clear?
yes, doctor.
Okay. Now coming to CT of the abdomen, CT of the adrenals, the same anatomy again. This is anterior, this is posterior, this is right, this is left. And here they didn't administer any intravenous contrast, okay? But you see what? Here you can see this is the abdominal aorta, and this is the right crus of the diaphragm. This is the left crus of the diaphragm. This is the spleen. This is the liver. And the white arrows are pointing at what? This structure and this structure. What are those? What are those?
Adrenal.
Yes. Why are they big? And the patient presented with a clinical picture of Addison's disease. So what is that? What is that? What could it be? It is very rare طبعا. Bilateral adrenal tuberculomas. Tuberculomas. Huh? Okay? This is how they look like. Okay. Now, this is another CT abdomen, axial cut at the level of the adrenal glands, showing anterior, posterior, right, left, the vertebra, the ribs on the right side, the ribs on the left side, the spleen, the liver, and this is the left kidney cut across, okay? This is the abdominal aorta. You see, inside there is something that is very white. What is this? What is this?
Calcification.
Yes, this is a calcified plaque inside the abdominal aorta. Very good. This is the right crus of the diaphragm, and this is the left crus of the diaphragm. All right. Here, the patient was given oral contrast. This is the intestine filled with gastrographene and air. Air is black. Okay. So what are the arrows pointing at? What are those?
The adrenal glands.
The adrenal glands. Why are they big? The patient presented with a picture of Addison's disease, hypocorticism. So what is this?
This is hemorrhage?
Yes, yes. It turns out this patient is receiving anticoagulant therapy for pulmonary embolism, but unfortunately he developed bilateral adrenal hemorrhage. Fresh blood or recent bleeding appears white, as if, bright, as if you have given intravenous contrast. But here the aorta appears gray, so no intravenous contrast was given. So if the adrenals are bright like that, it must have been hemorrhage. Okay, very good, excellent. طبعا this is something برضه very rare يعني ها. But I just show you the pictures for the for practicing how to comment on a CT abdomen. Okay. طيب. This is another CT abdomen, axial cut at the level of the adrenal glands. Is there IV contrast?
No.
Is there oral contrast?
No.
Yes. This is the intestine filled with dye.
Okay.
Okay. Dye. This is the vertebra, the ribs on the right side, the ribs on the left side. This is the abdominal aorta. This is the liver. Okay. This is the spleen. This is the right crus of the diaphragm. This is the left crus of the diaphragm. This is the right kidney. And what do the arrows point at? These globular structures, what are those?
Adrenal glands.
The adrenal glands, but they are globular, they are rounded, and they have a calcified rim, right? As if they look like a capsule with a calcified rim. So what could this be? This is something very rare. I have never seen a case, but Yani, this is from the internet, but I liked it, Yani. So I wanted to show you. What could this be? And the patient presented clinically with Addison's disease as well. What could be the cause? What is this? Huh?
I have no idea.
This is histoplasmosis, a fungal infection with bilateral subcapsular calcification of the adrenal glands. Something very rare, huh? But it's nice to show you the adrenals, how they can change size and change structure. All right? Is it clear? Any problem so far?
Doctor, I have a question.
Yes, please do.
Why most of the images the patients are taking oral contrast, not an IV one?
It depends on the maneuver or the technique that the radiologist is doing, because he can take pictures before giving IV contrast, but with oral contrast. So this is the picture. Or he can give both of them together at the same time, like we have seen in previous cuts. It depends actually on the technique. All right? But in any case, to visualize the adrenal glands, you have to write in your request CT abdomen adrenal protocol. Why? Because in the adrenal protocol, the thickness of the cuts is smaller than the usual abdominal CT. All right?
Okay, doctor, thank you.
Oh, yeah, you're welcome. Okay, so now let's look at this CT. Another CT abdomen, adrenal protocol, or at the level of the adrenal glands, axial cut like that, showing this is anterior, this is posterior, this is the vertebra, these are the ribs on the right side, the ribs on the left side, the spleen, the liver, but what are these structures inside the liver? And this is the abdominal aorta. Did the patient take any IV contrast? Huh?
No.
Yes, because the aorta appears relatively dark gray in color. This is the right crus of the diaphragm. This is the left crus of the diaphragm. Okay? But the loops of intestine are full of gastrographene. Okay? Now, what is this? And what is this? All this. And mind you, see the density of these lesions and compare them to these structures inside the liver. What could this be? And the patient presented with a clinical picture of Addison's disease. The patient presented with a clinical picture of Addison's disease. What could be the cause? Okay, what could be the cause? Who can tell me? Huh? What could be the cause? Come on, we're losing time. We're losing precious time. Huh?
Tumor
What
is
is
liver.
it? What is it? What is it?
No,
Huh? What is it?
I don't.
This is the patient presented with Addison's disease. Okay, so he or she, I don't know the gender of the patient, malignant melanoma, metastasizing to both adrenal glands and the liver. Okay, malignant melanoma is a very aggressive skin tumor. Huh? Okay, this is how it looks like. And mind you, adrenal metastasis can occur in different malignancies, not only from melanoma. It can occur mainly from breast carcinoma, lung carcinoma, and so on. Okay, all right. Are you tired, or do you want to continue? We have the pheochromocytoma and the what? The Conns. You want to continue?
I'm tired.
Continue.
We have like 30 slides missing, okay? Let's continue. Can you still see my slides? Huh?
Yes,
Yes.
but not in slideshow.
Okay, fine. Now, the slideshow?
Yes.
Okay. So pheochromocytoma. Pheochromocytoma, you know, the clinical presentation is usually a rule of 10. Namely, 10% are extra-adrenal. 10% occur in children. 10% are multiple or bilateral. 10% recur after surgical removal. 10% are malignant. 10% are familial. And 10% of benign sporadic adrenal pheochromocytomas are found as adrenal incidentalomas. Okay, the youngest patient with pheochromocytoma I have seen was a 10-year-old boy. All right, and regarding recurrence after surgical removal, I've seen Bordeaux a long time ago. A nurse, she was like 40-something years old. She had an adrenal pheochromocytoma on one side, which was removed in Mansoura, at Mansoura University. I don't know why she went to Mansoura. Anyway, she came like several years later with the same presentation of pheochromocytoma. It turns out it recurred after surgical removal. Okay? Okay? Is it clear? Now, the clinical presentation of pheochromocytoma can be either spell-related or not. The spell is the usual paroxysm or attack. It's composed of what? The patient will complain of anxiety and fear of impending death, diaphoresis or excessive sweating, dyspnea, shortness of breath, epigastric and chest pain, headache, particularly throbbing in nature at the end of the attack, hypertension, of course, it may be severe, nausea and vomiting, okay, pallor, pallor and not flushing. Why? Because pallor due to vasoconstriction, okay? Palpitations due to forceful heartbeat and tremors. But mind you, the clinical presentation in pheochromocytoma can be also chronic or in between the attacks. The patient may also feel anxiety and fear of impending death. The patient will have cold hands and feet due to vasoconstriction. The patient may have congestive heart failure due to dilated or hypertrophic cardiomyopathy. The patient may complain of constipation, again, diaphoresis and dyspnea. Rarely, very rarely, there may be ectopic hormone secretion dependent symptoms like ectopic CRH or ACTH secretion, ectopic growth hormone releasing hormone secretion, or PTH related peptide or VIP, okay? Vasointestinal peptide. There may be also epigastric and chest pain, fatigue, and fever, okay? There may be also general increase in sweating, grade 2 to 4 retinopathy, headache, again, hyperglycemia, yani secondary diabetes, hypertension, secondary hypertension, nausea and vomiting, orthostatic hypotension, painless hematuria. This is in particular associated with urinary bladder paraganglioma, pallor, again, palpitation, forceful heartbeats, tremors, and weight loss. Okay, this is the typical grade 4 hypertensive retinopathy that we could see in the 10-year-old boy who presented with pheochromocytoma. You see there is papilledema. The optic disc is not evident. There are cotton wool spots, these hard exudates, the yellowish spots, small spots, and flame-shaped hemorrhages. The typical grade 4 hypertensive retinopathy, all right? The typical spell or paroxysm is it's usually the symptoms of pheochromocytoma, they are episodic. So this is why we call them spells or paroxysms. And they can extremely vary in presentation, but typically all spells or paroxysms include a forceful heartbeat, pallor, again, pallor due to vasoconstriction, tremors, headache, and diaphoresis, okay? The typical spell may start with a sensation of a rush in the chest and a sense of shortness of breath, followed by a pounding heartbeat that typically progresses to a throbbing headache. All right? Peripheral vasoconstriction with a spell results in cold hands and feet and facial pallor. An increased sense of body heat and sweating are common symptoms that occur toward the end of the spell. Okay? And these spells may either be spontaneous or they may be precipitated by postural change or anxiety or some medications like metoclopramide or anesthetic agents, exercise or maneuvers that increased intra-abdominal pressure like change in position, lifting, defecation, exercise, colonoscopy, pregnancy, and trauma. Remember the nurse I told you about with recurrent pheochromocytoma? We used to show the spells or the paroxysms to the house officers and the students just by palpating her abdomen. Of course, it's something cruel to do, Yani, but we wanted to teach them how a spell looks like, all right? So just by palpating the patient's abdomen, the intra-abdominal pressure increased and the spell was precipitated. The spells may occur multiple times daily or as infrequently as once per month. And the typical duration of a pheochromocytoma spell is from 15 to 20 minutes, but it may be shorter or it may last several hours. However, you must recognize that most patients with spells do not have pheochromocytoma, okay? So the differential diagnosis is very large. Now, coming to the important thing, imaging in pheochromocytoma. This is again an axial CT abdomen at the level of the adrenal glands with contrast. Why? Here you see the abdominal aorta is a bit white in color, and this is the celiac trunk. Here is the liver, and the portal tracts are visible. And this is the right cross of the diaphragm. This is the left cross of the diaphragm. This is the right kidney. This is the right adrenal gland. And this, all of this, you see, this is a very large adrenal mass, okay, heterogeneous, okay, and it appears a bit vascular and partially necrotic. So this turns out to be a left pheochromocytoma. Okay? And this is the MRI, a T1 weighted image of the adrenal gland. Why T1 weighted? Because if you look closely inside the spinal cord, the CSF is black. Okay, so this is the vertebral body, this is the spinal cord, and the CSF is black. And this is the liver, this is the left kidney, the spleen, the abdominal aorta. It appears black because flowing blood appears black in a signal void, like I mentioned before. This is the right crus of the diaphragm. This is the left crus of the diaphragm. And all this is the right adrenal pheochromocytoma. It's rather big, 3.3 by 3.5 by 4.5 centimeters. And it is heterogeneous as well. All right. And this is the T2 weighted image. You see, T2 weighted because here, evidently, the CSF became white. Huh? So this is the abdominal aorta. This is the right crus of the diaphragm, the left crus of the diaphragm, the spleen, the left kidney, and the liver. And this is the big pheochromocytoma on the right side, heterogeneous again with the same dimensions. And it has a typical increased signal intensity on T2 weighted images. You see, the T1 weighted was like that, but in T2, no worries, and it became very white in color. Okay? Any problems so far? Huh?
No.
All right. And this is another scintigraphy. This is a radioactive iodine met-iodobenzoguanidine whole body scan. This is usually resorted to in problematic cases. This is, of course, very clear. This is the anterior view and this is the posterior view. Here you can see the radioisotope, the MIBG, concentrated in this large focus of increased radiotracer uptake in the left upper abdomen. So this is very obvious, but sometimes you cannot visualize a tumor in the adrenal. Remember, 10% are extra adrenal, either here at the organ of Zuckerkandel or near the stellate ganglion of the sympathetic chain. So in that case, if you want to localize where the pheochromocytoma is, okay, so you do this MIBG scan. And even though sometimes, in some cases, you cannot visualize pheochromocytoma, although the clinical picture and the metanephrines show that this patient has pheochromocytoma, but you cannot localize where the tissue is. Okay? A big problem. So, in that case, we can do an MIBG SPECT fusion CT images. Okay? The CT would show you the anatomy. This one. This is the axial, this is the coronal, and this is the sagittal, right? And the MIBG would show you the physiology, the function. Okay, like here, again, the axial and the coronal and the sagittal, right? Increased uptake, right? If you fuse both together, you can actually locate where exactly the tumor is. Of course, here in this particular case, it is very obvious the tumor is very big, but this is valid for very small or undetectable tumors with the usual techniques. Is it clear? Any problems? Huh? Can you still hear me?
Yes.
Okay. Okay, now Conn's disease. The clinical picture in many patients are actually asymptomatic. They have no symptoms, but they may have features of sodium retention or potassium loss. So sodium retention may cause edema, and hypokalemia may causes muscle weakness or even paralysis, especially in Chinese, the famous hypokalemic paralysis, and polyuria, secondary to renal tubular damage, which produces nephrogenic diabetes insipidus. And occasionally, tetany occurs because of associated metabolic alkalosis with low ionized calcium. All right. The investigations regarding the biochemistry, you do the plasma electrolytes to reveal hypokalemia and elevated bicarbonate. The plasma sodium is usually towards the upper end of normal range in primary mineralocorticoid excess, and it is characteristically low in secondary hyperaldosteronism because low plasma volume stimulates antidiuretic hormone release and high angiotensin II levels stimulate thirst. All right. Regarding plasma renin activity and aldosterone levels, if renin is low and aldosterone levels are high, then Conn's adenoma can be differentiated from bilateral adrenal hyperplasia by tests of aldosterone response to angiotensin II. In Conn's adenoma, aldosterone does not rise on standing or with furosemide administration. This is very typical. So in aldosterone secreting adenoma, aldosterone level does not rise on standing or with furosemide administration. In the rare circumstance when renin and aldosterone, both of them are low, you need to do further tests like measurement of urinary cortisol and its metabolites and 11-deoxycorticosterone. Okay? Almost all antihypertensive drugs interfere with these hormones. Beta blockers inhibit while thiazide diuretics stimulate renin secretion. So these should be stopped for at least 6 weeks beforehand. Okay? But if this is not possible, then antihypertensives which have minimal effects on the renin-angiotensin system, like calcium antagonists and alpha blockers, should be employed. All right? Now, to do localization, the only cause of primary hyperaldosteronism, which is usually treated by surgery, is Conn's adenoma. So abdominal CT is often the only test required to localize the tumor. Okay? But it is important to recognize that non-functioning adrenal adenomas are present in about 20% of patients with essential hypertension. And so adrenal CT should only be performed when the biochemistry supports the diagnosis of an adrenal tumor. And if the scan is inconclusive, then adrenal vein catheterization should be done with measurement of aldosterone and cortisol to confirm the proper positioning of the catheters, or you can do a radioactive iodine nor cholesterol scan. This is another form of scintigraphy. Okay? Anything not clear so far? Can you still hear me?
Clear, doctor.
Yes. Now coming to imaging, the last thing we're going to discuss today, imaging in Conn's disease. This is again a CT abdomen of the at the level of the adrenal glands, axial cut. Here is anterior, here's posterior. You know this by now. This is the vertebral body, the right ribs and the left ribs, the spleen, the left kidney, the right kidney, the liver, the abdominal aorta. Is the patient being given IV contrast here? Huh? Can you
Yes.
hear me? No. Why, yes. Yeah, the abdominal aorta is gray in color. It's gray.
Okay.
But he's given oral contrast. The intestine is filled with some dye, the yellow, the white parts, okay? And this is the right kidney, and this is the left kidney. The arrow is pointing at this lesion. This is what? Here, by the way, the crura of the diaphragm, maybe the right crus is visualized, but the left crus is not visualized. But the arrow is pointing at this tumor. So this is a left adrenal adenoma secreting aldosterone. Because we have done already the biochemistry and it revealed that the aldosterone is high and the renin is suppressed and there is electrolyte imbalance, right? And now you do the CT revealing this adenoma. So this is to localize the aldosterone secreting adenoma. Okay? And this is the radioactive iodine iodo-nor cholesterol scan, another type of scintigraphy. They have labeled cholesterol with radioactive iodine. Why did they choose cholesterol? Who can tell me? Why cholesterol? Come on, why cholesterol?
Because it takes part in the synthesis of the aldosterone.
Yes, very good. You see, all the adrenal cortical hormones They are based on, they have a building block, which is cholesterol. So they take cholesterol and they label it with radioactive iodine to visualize a tumor, an adenoma in the adrenal. Here, the tracer uptake is taken in the left adrenal gland. Okay? But this is not done routinely to visualize any adrenal adenoma. No, it is particularly used if you doubt that there is bilateral adrenal pathology. Because why? Because this radioactive tracer is taken up only by the adenoma, but not by the contralateral adrenal, which is usually suppressed. So in cases of Cushing syndrome, for example, due to bilateral pigmented nodular hyperplasia, in the CT, you may visualize only one side. But if you are in doubt, you better do the radioactive iodine nor cholesterol scan, because if you visualize both adrenal glands, so this means that there is bilateral adrenal pathology, okay? But if only one side is visualized, then the other adrenal is suppressed, so you have only a unilateral pathology. So this is the actual importance of radioactive iodo nor cholesterol scan. All right, and this is, of course, the surgical specimen. You see the tumor is removed. It is canary yellow in color because of high intracellular lipid content. This is how a Conn's adenoma surgical specimen looks like. Okay, is it clear? Any
Yes,
problems so far? Right, we have concluded all the revision I wanted to revise. Now is the time for the evaluation. Okay, so I will share with you the link of the evaluation in the chat, but if we cut off again, then please log in again through the same link that I have sent you on the WhatsApp group. Here, can you see the link? The link of the Google form in the chat of Zoom. And I will share my screen again with you.
Yes, doctor, it's available.
Type. Can you see my screen? Huh? Can you see my screen? The same questions.
Yes,
Yeah,
doctor.
it's very
Yes.
easy. The same questions like last time. The timing of the session was appropriate. The duration of the session was appropriate. The session was well organized. The content
Doctor,
of the session was very clear.
The document is not published.
How is that?
Yes, doctor, I have the same problem.
Stop here. Oh. Okay. Now, can you see it now? Can you see it now? The content of the session was very clear. The instructor was well prepared.
It needs access. We need access, doctor.
تاني برضه access.
Yes,
تاني
doctor.
like last time. Yeah, the rule. طيب. Where is it? Let me see. Yeah. Did you send me emails? It will cut off. طيب. Yeah, the rule. Yeah. Problematic, this one. This is why I don't like Zoom, you see. Microsoft didn't need any access. I have to do it one by one. How many are there in the meeting? Can somebody tell me, please? Because I don't see the participants. I cannot see them now. Can you tell me,
now
please?
We are 11.
You are 11, including me?
Yeah.
Yeah, and you are
it
10.
Was 12, now it's 11.
Now it's 11? طيب. Including me?
Including you.
Yeah, 10 students. So I need 10
students,
responses, please. I need 10 responses, okay? And make it quick before it cuts off, because there is no point in logging in again just for the questionnaire. Huh? Okay, now I give access to all of you. You're not 11, you're not 10. 1, 2, 3, 4, 5, 6, 7. Where are the 3 remaining? There are 3 students. Where are the rest of the 3 students? In the meantime, start responding. Start responding, please, to save time. So the timing of the session was appropriate. The duration of the session was appropriate. The session was well organized. The content of the session was very clear. The instructor was well prepared. There was adequate time for asking questions. What did you like most about today's session? What would you like to change in this session? Start responding, please. And I wonder why there are 7 students, only 7 students. Where are the remaining 3 students? Huh? You don't want to participate or what? Or they are not in the meeting. They are just كده pictures and names. They are not actually there.
يا دكتور محتاج اكسس بس للدخول.
Access. طيب ما انا اعطيك دكتور جمال. طيب اوكي. جمال، دكتور جمال، يلا. يبقى في 2 كمان. 2 more missing. 2 more students who are missing. ها؟ يلا. I have 2 responses now. 2 responses. يلا, make it quick. We have 3 more minutes to go. Because I need to read out the replies to you. يلا. 6 responses. No, you cannot have the PowerPoint presentations. How many students? Yalla, 2 more students to go. Yalla, what is keeping you? Doesn't take that much time. Yalla, the 2 who are remaining. Why are you not responding? Okay. Yeah, this is really very frustrating. Yeah, the only thing I ask you to please do is to fill out a very simple survey that takes only few minutes, like 2 minutes maximum. And while I have been talking my lungs out for the past how many hours? For 2 days. Yani, you don't give me the privilege of having this survey. Yani, this is really very frustrating. Anyway, the timing of the session was appropriate. 66.7% strongly agree, 33.3% agree. The duration of the session was appropriate. 66.7% agree, 16.7%, this is one, disagree, and 16.7%, this is another one, neutral. The session was well organized, 66.7% strongly agree, 28.6% agree. The content of the session was very clear, 85.7% strongly agree, 14.3% agree. The instructor was well prepared, 85.7% strongly agree, 14.3% agree. There was adequate time for asking questions, 71.4% strongly agree, 28.6% agree. What did you like most about today's session? The preparation, very motivated speaker. Comprehensive, simple. I like that there were many radiological features. More concern about imaging. What does that mean? Covering all topics. Very useful revision. Yeah. What would you like to change in this session? Nothing. The duration. Of course, it's long because we covered a lot of topics. Nothing. Can we please have the PowerPoint presentation? No, you cannot. Thanks so much. You're most welcome. So I thank you very much for your patience and for bearing with me and for having partly actively participated in answering my questions. And not all of you, of course. And I wish you the best of luck on your upcoming exam. Thank you very
شكرا
much.
لحضرتك جدا.
أهلا
شكرا
Thank you,
وسهلا.
جدا
doctor.
جدا
أهلا
جدا
وسهلا.
جدا.
أهلا وسهلا. يلا ارفعوا راسي بقى في الامتحان.